The November issue of JACC Interventions actually has a mini focus on radial access. We've done several interviews. May I introduce you to Dr. Olivier Bertrand, who is from the Quebec Heart-Lung Institute, an adjunct professor at the Department of Mechanical Engineering at McGill, and director of the Canadian Association of Interventional Cardiology Working Group. The paper that you have in JACC Interventions is looking at a clinical score to predict transradial failure. And you've analyzed a series of patients here. Tell me first about the group that you're looking at.
Yes, so thank you. So the first author of that paper, which we perform in our institution, is Dr. El Tigani Abdallah, one of my fellows. And we basically had the question that failure rates for radial PCI has been reported in the literature between 5 and 10%. But most of the time, those were either selected patient population or center with, let's say, moderate of limited experience. So because in our center we have been treating patients by radial approach for almost 20 years, well, we said, okay, we're going to look at everybody, all type of patients, and what's going on. So we basically analyzed the charts of more than 1,600 patients over 6 months, and we looked at the causes of failure to perform the PCI by the radial approach. And to basically trying to tease out some of the information, we divide these aspects in 2 categories. The first one is the primary failure, meaning that the patient goes into the lab and you don't even try. And this is called the primary failure. And we found it happened in 2.7% of the cases, so extremely low for any type of
unstable patient,
including cardiogenic shock patients, STEMI patients, all comers. So these are patients basically that will go in and we don't even try, either the fellow or the attendings, 2.7%. So then we have a second cause of failure, which is a crossover, meaning, for example, the guy will try to access the radial artery, the right, or even also try the left, and then he fail, and then for some reason you cross over to the femoral. And this happened in 1.8%. So the conclusion, number one, was that in all type of patients, in any clinical scenario, you will fail in less than 5% when you have experience, which obviously quite long-standing for us. But it's basically that you can treat the majority of patients in for any reasons by the radial approach, either the left or the right side. That's the first conclusion. Then we try to obviously look at the reasons. And basically by doing the classical multivariate analysis, we identified 3 independent predictors. The first one is female gender. It's quite obvious. They have, little artery. They may also be more difficult in terms of anatomical variation. So female gender appear one of the predictors. The second, patient after bypass. For some reason, they are sicker patients. They have a very long-standing coronary artery disease. And the third one is cardiogenic shock. So then we identify those 3 independent predictors, and we basically build or give them a value and develop what we call an integer score. And female has a value of 1, post-bypass has a value of 2, and shock has a value of 3. And then with that 3 simple parameters, we can predict a failure rate going from 2% to 80%. That's the second conclusion. But then the third aspect that we also were very interested, what happened with those patients who failed? Does that impact the prognosis? Is it the same? And it just because we do know the benefit of the radial approach, obviously, as well for the patient with the primary failure or for the crossover failure, secondary type of failure. Both of those group of patients have more ischemic complications, so the MACE rate during the in-hospital phase is higher, as well as the bleeding rate and the vascular complication rate. So overall, those patients, for some reason that we fail to obtain the radial access, have worse prognosis early and even for mortality up to 1 year.
So they're a high-risk population.
Exactly.
Sure.
So obviously, there may be some bias or selection bias. They are not exactly the same kind of patient because by definition we fail. Again, it's important to remember that we fail in only less than 5%. But those patients are particularly at risk. And one thing perhaps is that obviously we need to try to maximize the radial access for the whole type of patients. But perhaps we also should take extra care for the patient for some reason we fail. Also, as you mentioned, we have to recognize that for some patients, they may be so sick that whatever you're going to do, it's not really the access that matters, but the disease itself of other parameters.
I mean, this is one of the largest such analyses that's been done, correct?
Yes, well, I mean, as you know, in Quebec Heart-Lung Institute, we have a pretty large group of patients. We do something like more than almost 3,500 PCI per year. So it's quite easy for us to look at what we have been doing and just try also to critically see, evaluate and see if we can still improve. And for example, we cannot get access to the radial approach if the patient is in shock, he has no pulse. Well, what it may be for those type of patients, we should perhaps use the ultrasound guidance to puncture the radial artery, and because obviously once the guiding is in, I mean, most of the time, I mean, you will succeed.
We also did an interview with Dr. Berlakis, who has one of the papers in JACC Interventions, and his is on radial cabbage. And that study did exactly what you found, that this is a high-risk group of people.
I'm very well aware of Dr. Berlakis' work. I mean, there is a few very key differences. I think for a fact, and I think that Dr. Berlakis has been trained as a radialist, but I mean, this center is not using radial still as much as we do. So there is probably in terms of possibility for increasing. So obviously those patients are more technically challenging, and that may also impact. Second, this was a randomized study. So obviously then you have like inclusion, exclusion criteria. So then you just compare doing radial versus femoral in a selected population. And obviously you found some interesting difference that may also, I think, may improve over time.
And yours was a consecutive real-world analysis.
Exactly. All type of patients, all patients just looking at the database from the cath lab.
Well, this is the JACC Interventions for November, so please see Dr. Bertrand's paper there and the variety of others in the mini focus on radial access. For CardioSource World News, I'm Rick McGuire.